Medical news from MedRxiv. Automated detection of motor speech disorders and subtype classification. Early detection of motor speech disorders, MSDs, can flag the onset of neurodegenerative conditions before overt clinical signs appear, yet most patients never receive a formal perceptual assessment. In a large-scale machine learning investigation, researchers demonstrated that modern acoustic and self-supervised speech models can identify MSDs with near-clinical accuracy, achieving sensitivities above 90% and specificities approaching 98% when tested on data completely external to the training set. This level of performance suggests that automated speech analysis could soon serve as a reliable frontline screen for a range of neurological illnesses. Motor speech impairment underlies a substantial burden of disease, contributing to communication loss in Parkinson's disease, amyotrophic lateral sclerosis, progressive apraxia of speech, and other disorders. Conventional diagnosis relies on expert clinicians who listen for subtle articulatory breakdowns, a resource that is scarce outside tertiary centers. Prior work has shown that static acoustic descriptors such as mel-frequency cepstral coefficients, MFCCs, or the extended Geneva acoustic parameter set, EGU-MAPS, capture some variance, but systematic comparisons across modeling strategies and validation on truly independent cohorts have been lacking. The present study therefore set out to benchmark a spectrum of approaches, from handcrafted acoustic features to cutting-edge self-supervised neural representations, and to evaluate whether these tools could not only separate patients with any MSD from healthy controls but also discriminate among 6 clinically defined subtypes. The investigators assembled 583 speech recordings drawn from multiple clinical sites, ensuring that each participant contributed only one sample to avoid leakage across training and test partitions. Data were split at the speaker level, preserving independence between development and evaluation sets. Baseline classifiers comprised logistic regression models trained on EGU-MAPS and MFCC features, as well as gated recurrent unit (GRU) networks that ingested the same static descriptors. To capture more nuanced articulatory information, 3 families of phonet-derived features, derived from forced alignment phoneme timing, spectral shape, and prosodic dynamics, were extracted and fed into GRU architectures. In parallel, the team leveraged 2 large self-supervised models, Hubert and the Self-Supervised Audio Spectrogram Transformer, SAST, probing 3 training regimes, frozen, using pre-trained weights unchanged, partially fine-tuned, updating only the final classification layers, and fully fine-tuned, allowing all parameters to adapt. Binary classification tasked the models with distinguishing any MSD from control speech, while multi-label classification required simultaneous prediction of 6 disorder subtypes. Performance was quantified primarily by area under the Receiver Operating Characteristic Curve, AUC, on a held-out validation set, and the optimal operating points were then applied to 2 external datasets to assess generalizability. Across the board, models that incorporated either phonet-derived representations or self-supervised embeddings outperformed those relying solely on static acoustic features. In the binary task, the fully fine-tuned Hubert network achieved the highest validation AUC of 0.95, closely trailed by a compact GRU built on phonet features that reached an AUC of 0.94. When these thresholds were transferred to the independent cohorts, the Hubert system preserved a sensitivity of 0.94 and a specificity of 0.97, while the phonet GRU retained a sensitivity of 0.92 and specificity of 0.96, metrics that rival those reported for expert auditory perceptual ratings. For multi-label classification, the phonet-based GRU attained a macro-average AUC of 0.88. With individual subtype AUCs ranging from 0.80 for dysarthric phenotypes to 0.92 for apraxic speech patterns, the fully fine-tuned Hubert model, although slightly lower overall, macro AUC is almost equal to 0.84, demonstrated comparable per-class performance after calibration. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.